like the classic bone on bone, can't walk 100 feet without stopping in pain.
Mm-hmm.
And his orthopedist told him, "Now, I do not prescribe opiates. Go see your primary care doctor." 10, 15 years ago, everybody was getting 100 tablets of 100 milligrams of everything.
Mm-hmm.
And now, nobody's getting anything. Welcome to your daily health briefing. I'm Dr. Albert Tackett. This show is here to help you navigate the complex U.S. medical system, one step at a time. Whether you are decoding a new diagnosis, fighting for a referral, or just trying to stay informed, you are in the right place. Let's get into the science. Over the last decade, opioid laws and prescribing guidelines have dramatically changed how doctors treat pain. These policies were created to stop addiction and save lives, but they also created fear, hesitation, and sometimes unintended suffering for patients. Today, Dr. Tiffany Ross and I are discussing how pain policy has changed the doctor-patient relationship and how physicians can still advocate safely for patients who truly need pain care. Welcome to the show, Dr. Ross.
Thank you, Dr. Tackett.
So let's tackle one of the biggest issues in medicine, which we talked about in another episode, the fear and reluctance of doctors for prescribing opiates. Now, I am not an advocate for free-for-all opiate therapy, but I was shocked when one of my patients came to see me, and he's coming from his orthopedic surgeon. And this is a guy who went to see the orthopedist because of severe bilateral chronic knee osteoarthritis, like the classic bone on bone, can't walk 100 feet without stopping in pain.
Mm-hmm.
And his orthopedist told him, "Now, I do not prescribe opiates. Go see your primary care doctor." And I was dumbfounded by that statement.
Mm-hmm.
And this is why I wanted us to talk about this, because it seems like the pendulum has swung completely the other direction. Like 10, 15 years ago, everybody was getting 100 tablets of 100 milligrams of everything.
Mm-hmm.
And now nobody's getting anything. Why are we in this situation?
Yeah, I think we've seen this kind of huge shift. We talked about, in the early 1990s, we started seeing overdose from these medications, and kind of gradually over time, the number of overdose due to opioid deaths has increased. And so clinicians have a real fear of prescribing. They don't want to put patients at risk. We kind of know the downsides, but there are patients, like you said, who legitimately need these medications, and we shouldn't be under-treating their pain, and we should be either pointing them to the right resources, such as pain management, if they don't feel comfortable in prescribing. But I do see a lot of clinicians who are fearful, even for patients who they've operated on. They don't want to continue, writing medications, and it's, indicated for surgical-related pain. So there definitely needs to be, like you said, we need to be good clinicians and make good decisions for our patients and still treat them appropriately.
And this is even before the patient goes to the pharmacy, because it seems to me all pharmacists look at patients sideways when they come for a pain medicine prescription.
They do, and it's really unfortunate. My patients say I've experienced a lot of stigma. These are medications that I get all the time, and I feel like the pharmacist is reluctant to prescribe the medications.
Mm-hmm.
There are other barriers in terms of, the insurance company, the prior authorization that we all dread and hate.
Mm-hmm.
But, the insurance companies are, requiring urine drug screens. They're requiring opioid contracts from the patients. They want to make sure that the prescriber is, looking at that prescription drug monitoring program.
Mm-hmm.
And so that prior authorization process can take weeks. So that's a even further kind of delay of care. So there are lots of hurdles and hoops that sometimes patients feel they have to jump through.
I had a patient who came to see me in Maryland, and of course he lives in Virginia. We live in the DMV,
Mm-hmm.
where the borders are blurred,
Mm-hmm.
basically. And he went to the pharmacy and they said, well, the doctor is in Silver Spring and he's picking up the prescription in Arlington.
Mm-hmm.
They won't fill it. What is the issue with that, and how can we help patients navigate that problem?
So I get that in a sense. If I live in Maryland and I have a patient in California, and yes, I lived in California and practice and have a license there, but if I were to try to prescribe medication for a patient who lived in California to the pharmacist, that looks like there's, something awry or something negative going on. And this person is going to different physicians out of state to seek medications. In the DMV, the lines are so blurred. DC is, 5 minutes from Maryland, 5 minutes from Virginia, kind of depending on where you are. And even though you don't have a license in that state, just due to proximity, you should be able to prescribe for your patients. But that is a real thing, and it's up to the discretion of the pharmacist. I have patients who I see who, even in the state of Maryland, if I'm, more than 60 miles from where I practice, the pharmacist can say, I don't feel comfortable with prescribing this medication. Why are you seeking physicians kind of outside of your network? And that isn't fair to patients because they can determine or go where they feel they're going to get the best quality care, kind of regardless of geographic area. So sometimes it's just calling the pharmacist and explaining to them what's going on, and that sort of, clears up things. But that is a barrier or an issue that they face.
Let me give some pushback to the whole healthcare system, doctors and pharmacists. In a case like this, why doesn't the pharmacist pick up the phone and call the doctor and say, hey, did you see this patient? Is he your patient? Is this a legitimate prescription?
Probably because they have so many patients, and that may be difficult to kind of accommodate within the day. But I definitely have pharmacists who call the office and say, hey, have you seen this patient? Have you seen them in the last month? I have some concerns, because it's their license too, and they're still held responsible for any medications that they fill.
So as a patient navigating this system, I would say what we want the patient to think, or what we would like the patient to think, is that the pharmacist is doing his due diligence. It's part of the system to protect the patient from drug diversion, from drug dependence, tolerance, and all the problems that come from narcotics. But the pharmacist and the doctor need better communication.
They absolutely do. And I routinely call the pharmacist multiple times to explain, why I'm writing certain prescriptions, who I am, so that I have a good relationship too with the pharmacist in my area.
Because it's usually a problem with a lot of patients. They get very frustrated when they go to the pharmacy. They're looking at them sideways like,
That too. And it's not just the pharmacist. A lot of times the pharmacies are not able to keep certain medications in stock. They have to order them. They're limited to the types and the dosages that they can keep in stock. And so that becomes another barrier for patients as well, particularly for narcotics.
Because we've known people break into pharmacies.
Absolutely.
To steal narcotics. So it's a real problem.
It is a real problem. And I tell patients, I don't have any control over the pharmacy's distributors. And so there could be a delay in care simply because they have to order the medication. And it's very frustrating.
Yeah. And they have good reasons not to stock up on those medications. Okay, so this whole world of pain management is really complex for patients. It sometimes feels like they can't win, right? If they're trying to deal with pain, they get labeled addicted to pain medicine. If they ignore the pain, they develop depression, anxiety, and all sorts of functional problems. How do we help a patient who has all these things and then also needs to work? Maybe needs a dependent of transportation physical, needs a certification. How do we help the patient deal with the pain at their job?
I think the underlying thing is the sooner you refer to pain management, the better. Sometimes by the time the patient sees me, they've been dealing with this for months, years, trying to get an appointment, and we can certainly help them sooner. I routinely fill out FMLA paperwork, work accommodations to help patients, continue to function and do the things that they need to do while they're recovering.
So, Dr. Ross, I'm one of your patients. I have really bad right knee pain. And it's really impacting my ability to enjoy life, my job. And my primary care doctor does not really pay attention to that right knee pain. It's more focused on managing my blood pressure and diabetes. What conversations do you think I should have with my primary care doctor?
Yeah, so I think the fact that you mention the area that bothers you the most and then prompt your primary care doctor to get imaging, right? Imaging kind of dictates and guides treatment. Having a referral to a pain management doctor who can help coordinate making sure you get into physical therapy and just remembering to continue to be active, right? Inactivity, I say, is the absolute worst thing that people can do.
Inactivity. But the knee hurts.
I know it hurts, but guess what? Sitting and not doing anything will make it harder in the long term to continue to move. So the worst thing you can do is sit and do nothing, right? Go to your primary care doctor, have a conversation with them that can prompt them to get some additional imaging. You may get a referral to pain management who can then make sure you're plugged in with the physical therapist, and then we can talk about procedures, other options to help significantly reduce the pain so that you can get back to continuing to move.
So the presence of pain should not be a limiting factor to activity.
No, absolutely not. The worst thing you can do is sit and do nothing.
Okay. So before I let you go, let me ask you another question that I get from patients all the time. Doc, I was playing basketball yesterday and I went for a rebound and then I heard something pop in my back and I've since been having this pain. It's been 3 weeks. I need an MRI.
Okay, so we can't just jump directly to, I say the MRI is the HD TV, if you will, of imaging, all right? And your insurance company is...
Your MRI is the HD TV of imaging.
Yes.
Okay.
HD quality imaging. And we can't just jump to that, okay? Let's start with some basic imaging, an x-ray first to see what's going on. Let's try Tylenol. Let's try ibuprofen. If it's been several months, things are getting worse, then we will order that additional imaging.
Now, this is a part of the story where the patient fired me.
Oh, no.
And went to a different doctor because he wanted the MRI.
Guess what? Insurance also dictates when that MRI gets paid for. And a lot of times they'll say, have you seen this person for several visits? Have you already done physical therapy? Have you tried Tylenol and ibuprofen? What does the imaging say? If the imaging doesn't say anything, they are less likely inclined to approve that MRI.
Why is that? Can we explain to patients? Because, patients, this is a part of the story where they sometimes feel like either A, the doctor is blocking their care, is the gatekeeper, or the insurance just doesn't want to spend the money. And sometimes I have to explain to the patient that the MRI will not fix the pain. It's just another tool, and likely than not will not show anything. Why do you think patients don't believe that story, and how can we educate them on that?
Yeah, so I always reframe patients, how to think and how to process things, right? An x-ray takes a few seconds to do in terms of costs. It's low cost and a really quick test that we can do to help us. It may be that you end up doing physical therapy and doing Tylenol and ibuprofen and things resolved. And then it could, essentially be a waste of money to order this HD TV imaging that you don't actually need and could end up finding things that, you didn't intend to find. And that's something we call incidental findings. So there's always risk and benefits in terms of everything that we do. And it's not that we're trying to be gatekeepers or, keep them from moving forward.
How about the common patient gripe that the pain has been there for like 3 or 4 weeks? I think there's something worse going on. How do you reframe patients' expectations towards pain resolution? How long it takes actually for pain to go away? Because I had to tell a few patients that I hurt my left shoulder doing bench presses 2 years ago, and it still hurts to this day. It doesn't hurt as bad as it was 2 years ago, but if I bench press anything over 100 pounds, it still hurts.
Yeah.
How can I tell the patient that I'm not going to lose the shoulder? Because that's always your fear. Doctor, there's something underneath. Is there something worse?
So it depends on what's going on, right? When we think of muscle strain or, tendon tears, partial tears, there's a timeline of recovery. And it's not overnight and it's not 1 to 2 weeks. It could be several weeks.
Could it be several months?
Could be several months. And it could be that it doesn't repair itself, but it may not be as bothersome as it initially was. But guess what? You can't just stop moving. You have to continue to move through the discomfort. So I say, if things are getting worse, right? If you're starting to have neurologic symptoms, meaning you're dropping items, you're feeling like your arm is weak, you're having severe numbness, tingling, and I say, hey, let's get that additional imaging because it may give us insight into what else is going on and can help guide and direct our treatment.
Our classic red flags.
Red flag symptoms. Yep.
All right. Thank you so much, Dr. Ross. As always, very enlightening.
Welcome.
This has been the Daily Brief. Medicine is not about certainty. It is about responsibility. Decisions are often made with incomplete information, but they are always made with your safety in mind. In a system that can feel rushed and fragmented, you deserve clarity, continuity, and an advocate who sees the whole picture. I am Dr. Albert Tacken, your physician ally, high-level science, human-level care. I will see you at the next briefing, or I will see you in the clinic.